I'm actually not going to talk much about risks because we know that platelets have risks. We know that FFP have risks. We know that from SHOT. And every single publication that I've seen says, oh, we looked at our patients who had FFP, or we looked at our patients who had platelets, and then we compared it to the ones that didn't need that, and they did worse when they had FFP and platelets. But the problem with that is it's just an observation that a patient who's had a great big hemorrhage requiring blood product intervention has a different outcome than a patient who doesn't, and there's not a causality. That's the difficulty when you're talking about risk of these blood products. You need to design the right type of study to actually look at causality rather than just association. I suppose my question, you may not agree with it. What is the ideal blood product during a massive hemorrhage? If you had a choice of, I guess, I mean, this would be my assumption. The best thing you could possibly give someone would be fresh whole blood, because you give them the red cells, you give them the plasma, you give them the platelets, and you know whether that's actually true, but it makes sense that would be the case. And you shouldn't therefore need platelet and plasma transfusions. And there is evidence for this. I mean, the initial publication came from soldiers in Vietnam. Basically, they weren't needing platelet transfusions, whereas if you've had, say, 10 units of SAGM, you're probably going to need platelets. Unfortunately, we're never going to have whole blood. But I suppose this is the reason that we have to start thinking about managing multiple products, because we're giving red cells that are resuspended in solution. These are a few facts and figures to get started with. I'm not actually quoting any bleeding figures from the UK, partly because I don't want to air our dirty laundry about how many people bleed where I work. So I'm quoting a few Canadian and American studies. So I suppose one of the first question is, if someone is not allowed to have any form of primary blood product, what's the chance they're going to make it through cardiac surgery? So the biggest publication of Jehovah's Witnesses I could find was that Maraca study at the top, and essentially I have 40 patients, and half of them were actually quite high-risk procedures. 2 of them died, and I guess looking at the paper, they perhaps would have survived if they'd have had blood products available. So I suppose the mortality rate is not that high if you don't actually have any recourse to primary blood products at all. And in terms of the actual volume, I mean, a bit of this we'll talk about this morning, but cardiac surgery apparently accounts for 10 to 15% of the total American blood supply. So obviously, cardiac surgery is a major user of all blood products. I've quite a bit of Canadian data there. So for coronary artery bypass graft, they say that 40% of the patients receive red cells, 20% receive plasma platelets, and 8% of them have a bleed, which would then become a large volume transfusion. And I've just quoted, there's a financial issue as well. I mean, this is just what we spend on blood products in for cardiac surgery patients, spending well over £250,000. And the vast majority of the non-red cell budget is spent on platelets because they're quite expensive. So what about this coagulopathy of cardiopulmonary bypass? So there's obviously consumption of clotting factors and platelets. There's hemodilution, there's blood loss, and there is thrombin generation and fibrinolysis, which may be partly to do with the fact that the blood's in contact with artificial surfaces and things like that. And I think platelet dysfunction is well recognised. I'm not going to talk about that. So it's not just a numerical issue with platelets, it's a function. Certainly the guidance, we've been looking at the thoracic surgeon's guidance, the one from 2011. It does recommend point of care testing in conjunction with transfusion algorithms to reduce transfusion requirements. And there are risk scores that you can develop to predict bleeding. I'm not going to talk about these. I'm more interested in why is it we're giving FFP to people. Okay, so this is what I'm going to start to address. So why do we use FFP, and what exactly are we replacing in patients having cardiac surgery? So this Canadian study, it took 103 patients who they considered to be having complex cardiac surgery. So they excluded anyone who's having routine surgery, all requiring cardiopulmonary bypass. There were 2 centres. You can see that Centre 2 had a higher blood usage, and they had more urgent cases and a higher complexity. And Centre 1 apparently were using heparin-coated cardiopulmonary bypass equipment, so I don't know whether that's contributed as well. So FFP use is quite high, 42% in one centre, 63 in another, platelets 22 and 49, not much cryo used actually. So lots of non-red cell products used, average blood loss 952, so complex surgery. And what they did is they looked at all the clotting factors after they came off bypass. They looked at hemoglobin dropped, platelet count dropped, INR went up a bit, fibrinogen dropped a bit. Factor 2, that's prothrombin, 50, went down to 50. It didn't go that much. I mean, obviously there was a bit of variance, but it didn't go that low. Factor 5, 50. Factor 8 stayed quite reasonable at 100. Factor 10, 50. Factor 13, 70. There's plenty of old experimental evidence to suggest that you can get away with levels down to 30, 20 for factor 2, less than 30 for factor 5. Factor 8 and factor 9 probably need levels of about 50 or 60 maybe in a surgical context. So actually, they didn't find any factor was going down below the level where you could get adequate hemostasis. And they looked at whether any of those factor drops were in any way predictive of bleeding, and they weren't. The only thing that they found was predictive of bleeding was a previous stenotomy, the platelet count after bypass, and I was quite interested to see about this mini bypass thing and having a higher platelet count at the end of that, because I just wonder whether that sort of thing may make a difference. And the fibrinogen level. Only predictors, not clotting factors at all. And this is another study, which is this one's a European one. And again, they looked at factors 2 hours post, and then 24 hours post. So they looked at factors 2, 5, 10, 11, and 9, and fibrinogen. None of these factors were anywhere near, even down to 75%. They weren't even going to 75%. These are CABG patients on bypass. So none of these factors are actually dropping to a level that you would think we need to give some FFP to replace these factors. They again found a relationship between fibrinogen and blood loss, and they also found a relationship between factor 13 and blood loss as well. We know in terms of studies that prophylactic FFP does not improve blood conservation. You do not bleed less if you use FFP instead of colloids and crystalloids during bypass. So using it prophylactically does not reduce bleeding. And so my question is, in the absence of major hemorrhage, because obviously if someone's having a massive hemorrhage, you are going to have to give them platelets and FFP because you're going to basically deplete yourself of those factors. But it's about a non-massive hemorrhage. What is the evidence to support the use of FFP? Because certainly the coagulation factor assays that I've just shown you in those two studies do not really support. So I guess my question is, what is it you're replacing? What is it in FFP that you're giving to the patient that they need?
Volume.
Yeah, volume, partly, volume. Right, and is it fibrinogen? Yeah, I mean, you talking about this afterwards. I'll try, I hopefully won't cross over too much, but I mean, fibrinogen is the most numerous, in terms of molecules, there's a lot of fibrinogen molecules around because it's a cascade. You start at the top with a few molecules and you end up at the bottom with a lot. So there's a lot of fibrinogen around. It has functions other than just forming fibrin clot. We know it activates platelets through the 2B3A receptor. So it has a sort of synergistic effect with platelets. We know that high fibrinogen levels predict less bleeding for surgery and low levels predict more bleeding. And we know there's lots of fibrinogen in cryoprecipitate and a lot less in FFP. And are you showing this in your... No. So what they did, this is an in vitro experiment. So what they did is they diluted patients' blood, control blood, down to about 85% dilution. And you actually get a dilution of coagulopathy in vitro. And then they used a TEG, and they just kept spiking more and more fibrinogen into it. And what they found was, these are all TEG parameters, angle, MCF, CT, CFT. They could normalize a TEG when they managed to supplement the fibrinogen concentrate up to 2 grams per litre, actually, not decilitre, sorry. So we often talk about fibrinogen thresholds of 0.5 or 1 or even 1.5 more recently, but what they showed was if you get fibrinogen up to 2, in an in vitro experiment, you will correct the TEGs. So that's in vitro. So you say, okay, fair enough, that's in vitro, but what about clinically? Have you got this one on? Okay, I'm really sorry about that. So this particular study, only 10 patients in each arm. I think I think when they gave the fibrinogen concentrate, I think the surgeon who was doing the operation wasn't knowing whether they'd had fibrinogen or not, because it was given in I think in the anaesthetic room. So they're showing essentially, this is a clinical study now. They're showing that if you give what is relatively just tiny amount of fibrinogen, 2 grams of fibrinogen is a really small amount, you're actually getting less patients requiring blood transfusion, and you're getting better hemoglobins at the end of your cardiac procedure. And the only abnormality they could find in terms of coagulopathy was that there was a higher D-dimer in the group given fibrinogen. I guess if you're giving fibrinogen, it's a substrate for fibrinolysis. And in terms of adverse effects, day 3, I think, they did a total body CT scan. And they found that in the fibrinogen group, there was 1 subclinical peripheral PE and 1, I think, partial vein graft occlusion. And in the control group, they had a perioperative MI. So, when I asked the question, what is it in FFP that we're replacing, I actually don't know the answer, but it does look like fibrinogen is important. And we use cryoprecipitate in this country, partly because I don't think fibrinogen concentrate is yet licensed, but I'm not going to talk about that anymore because you're talking about that. So, short and sweet this. So, I suppose when we're talking about non-red cell products and treatment for cardiac surgery, should we be focusing on things where we know it makes a difference? We know that there's low platelets and platelet dysfunction, and it looks like fibrinogen is important. That's very similar clinical bleeding picture, actually. If you've got they tend to ooze, don't they? Oozy patients but it can be either low platelets or low fibrinogen. And there seem to be some synergism between the two. And it looks as if giving fibrinogen might even improve platelet function. So I suppose we should really be, and I know that's the title of one of the sessions, looking at point-of-care testing, which, although imperfect, may help guide giving the right product to patients. And fibrinogen supplementation is interesting, and you're going to hear more about that. I mean, this is, because I've got a moment, I still struggle with the idea of colloid, because there is some evidence that if you give colloid instead of crystalloid, you will affect the quality of fibrin formation. So you've got a crystalloid dilution and a gelatin dilution. I mean, this is in vitro experimentation, but you are affecting the way fibrinogen polymerizes when you give colloids. So I suppose one of the questions is, when you give an FFP, is it because you're giving less colloids? Is that one of the benefits? Although those studies that used FFP instead of colloids prophylactically did not show any benefit. And the other thing to bear in mind is that we all like to measure class fibrinogens. It's the more functional screen of fibrinogen, but it's actually affected by HES. You actually get a falsely high level. So you may, not only are we probably using too low a cutoff for when we give fibrinogen, but we're also maybe getting false readings that are giving us false reassurance. So I will finish on that. Thank you.
Can I ask a question both for Will and Helen? But first of all, show of hands, who's using TEG? See, the majority of people, I thought so. How many of you are participating in a National Quality Assurance Scheme? Okay, because I'd like you to comment briefly on that, about the importance of quality assurance and testing.
Yeah, I mean, this is our local issue for us, actually. Absolutely no quality assurance testing at all. We're just using it, out of the box. I mean, if you're going to, we need to be looking at what point of care tests we're using and what sort of information they're giving to us, and we need to know that our device is performing well. So, it's a big issue, because I think we got guidance telling us that we really should be using more point of care testing devices. So we're being told to do that, but we're not backing that up with sort of the quality checking, really.
The National Quality Assurance Scheme for Coagulation, of course, is looking at point-of-care testing, and they're developing a scheme for TEGs. And the preliminary studies that they've done do demonstrate that the results are quite variable. So what you see is what you get, but it might not be the same as next door. And thanks. I think the other really important thing is about who does the tests and how they're trained to do them, because if you have people who don't know how to do them properly, you get rubbish in, rubbish out. Enough for me. Somebody else.
Just to comment on point-of-care testing, it would seem foolish if you had no quality assurance in place in any centre. I mean, our centre, our laboratory does our quality assurance for all our point-of-care machines.
Yeah.
And they should. And anyone that is using it and they don't have quality assurance, I'm not sure that you can reliably use those results. I agree that you need to find some people who regularly do the tests, but having said that, a seismic coagulometer is not a difficult machine to use because I can use it, and I can guarantee it's not difficult to use it, I can use it. One question I have with you for fibrinogen, I'm sorry this impinges on the talk earlier, there are a number of haematologists I've spoken to who are significantly concerned about historical data to do with acute myocardial infarction and fibrinogen. I'd just like to know your thoughts on that.
I think that fibrinogen is going to turn out to be really key in terms of getting the dose right. I think if you give a bit, you will reduce hemorrhage. If you give too much, you're going to cause thrombosis. I think it is, you know, I don't know if it's going to be as bad as aprotenin, but I do.
How does fibrinogen cause thrombosis if it's not a thrombin generator?
I don't know. I mean, it is a well-recognised, you know, having a high baseline fibrinogen level increases your risk of getting venous thromboembolism. We know that it is, just having a higher level appears to be, I mean, you know, we all sit somewhere on that sort of, you know, coagulation, you know, hemostatically, you know, some of us are bleeders, some of us are clotters. Fibrinogen seems to send you that way a little bit in terms of the whole homeostatic balance, just because of just numerically having a higher fibrinogen. I mean, one of the difficulties is that some people with higher fibrinogens have got endothelial disease and cardiovascular disease and other things, but it does seem to be an independent marker of thrombotic risk. And I think it is going to be key to modulate it in surgery. Yeah. And we give tranexamic acid and aprotenin, that works by stabilising fibrin clot, doesn't it? I mean, we know it's important. Yeah.
Can I just add to that? I think when you've got a bleeding patient, we looked at about 500 of our trauma patients, and when they're bleeding, you can give them up to, within their massive hemorrhage, up to 40 grams of fibrinogen within FFP and within cryoprecipitate. And at 24 hours, their fibrinogen level is no higher than those that got significantly less. And so when they're actively bleeding, you are consuming and using that fibrinogen up. So that's something else that we need to find out about as well.
Your fibrinogen does flick up after cardiac surgery. Anyway, it does flick up, so you have to be careful. Yeah, it does have acute phase, yeah.
Good. Well, I think thank you very much, Will. I think there's a lot more discussion to come. And,